to this session of the Qualitative Methods Masterclass webinar series. This series of webinars is sponsored by International Institute for Qualitative Methodology, University of Alberta, and ATLAS.ti, Software for Qualitative Data Analysis. I am Neringa Kalpokaite, official instructor of ATLAS.ti, and I will just introduce a few technical concepts you need to know before we start with this presentation. This presentation will be conducted through GoToWebinar, system for web conferencing. So if you happen to get disconnected from this session, you just have to click again on the link received from GoToWebinar. If the presenter of today's presenter, Carl May, he disconnects, he would do exactly the same thing. But in that case, please be patient. It may take just a few seconds to him to come back. But I hope that none of this will happen today. So we are happy today to have with us Dr. Carl May, who will present for about 30 to 45 minutes. And after that, he will take questions. During the presentation, the microphones will be muted in order to avoid background noise and echo. But please feel free to write down all your questions in the question pane during the presentation. After the presentation, I will read all your questions, and for sure, Dr. May will answer those questions. In fact, you can just try right now to say hello and to practice with the control panel. On the other hand, you can use hand icon. After the presentation, if you would like to speak, you just have to click on the hand icon and I will give the microphone to you. So, now I am going to give the microphone to Amanda Schuyer, the Director of International Institute for Qualitative Methodology, and she will introduce today's presenter. So, Amanda, I will give the microphone to you right now. The microphone, just in a second, will be yours, Amanda.
Thank you, Neringa. Can everyone hear me okay?
Yes, I think so.
Okay, excellent. So I'm very excited to introduce Dr. Carl May. Carl is a professor of healthcare innovation in the Faculty of Health Sciences at the University of Southampton in England. Carl studied social and economic history and sociology at the University of Wales, Aberystwyth, and medical sociology at the University of Edinburgh, Scotland. His doctoral research focused on professional-patient interactions in terminal care nursing, and Carl's theoretical work has focused on developing conceptual frameworks that help in understanding implementation processes and healthcare delivery, experiences of complexity, burden of treatment, and the need for minimally disruptive medicine, and most recently, relational work across strategic action fields and social networks. His leadership of the international collaborative that has developed and applied normalization process theory is at the center of these activities. Without further ado, I will hand it over to Carl.
Well, thank you so much, Amanda.
Thank you, Amanda, and thank you, Carl. Just give me a second, Carl, to make you as a presenter right now. Okay, give me just a second to do it. Okay, you should receive now a message that you have to accept to be as a presenter of today's session.
Okay, all right. Now I am showing my screen.
Yes.
Well, I was showing my screen and now I'm not. How do I get rid of this?
It's okay, now I can see your PowerPoint presentation.
You can see it, can you?
Yeah, I can see it.
Okay, but actually I can't get to this, which is what I want to get to.
Perfect.
Okay, all right, that's good. Okay, well, lovely to talk to everybody, and I just have a big blob of your I've got rid of it now. So anyway, I'm Carl May. I'm a sociologist, amongst other things, and what I'm going to talk about today is some of the work that I and colleagues have done about theory development across the field of implementation science. So I'm going to begin, of course, by acknowledging not just my many friends, but also the Economic and Social Research Council in the UK, who've paid for a lot of the work that I'm going to discuss, and whose support has been really first-rate for a long time now. Many of you will recognise some of the names amongst acknowledgements here, but there are a whole crew of other people who don't fit on the slide. And one of the things I was going to put up was a slide full of pictures of us all in different restaurants around the world, but I was discouraged from doing that by somebody who perhaps felt that that might give the wrong impression of them turning up in every picture in every restaurant around the world. So there we go. A little bit of an introduction to my work. For most of my career, I've been what I call an old-fashioned medical sociologist. I've done work about professional patient interaction and healthcare inequalities, but I've also developed a program of work about innovation and evidence, and much of that's been focused on new technologies, especially telemedicine systems. And for about 10 years, I had a program of research on telemedicine based at the University of Newcastle in the north of England, where I was then working. And all of this work made me think hard about why it was that clinicians and healthcare providers seem to have such difficulty in getting innovations into practice, and especially getting technological innovations into practice. So I'm thinking about something slightly different from the work that many people do, and especially in Canada, about knowledge transfer. I'm thinking about new technology implementation and practice implementation too. My empirical research has been almost completely qualitative, and it's included ethnographies and interview-based studies, but also over a few years what I come to call explanatory systematic reviews. And I'm going to be talking about one of these later on in the seminar, where we use theory to structure the interpretation of data collected in a systematic review. Over the past decade, the thing that I've become most interested in is theory building. And for those of you who are British or perhaps Canadian, you might remember from your childhood the author of children's novels, Arthur Ransom, and he wrote a book called We Didn't Mean to Go to Sea, in which a group of children accidentally set off in a yacht and sailed from England to the Hook of Holland in the Netherlands and back. And my sort of theory building program has proceeded on that basis. I never intended to do theory building. I never intended to write theoretical papers. I was very content as an empirical researcher. But as we'll see in a little while, I began to develop theoretical models. Much of this work has focused, as I've said, on implementing new technologies and new forms of clinical practice. And I've got a definition here of implementation. It's a very broad definition, but what underpins it, of course, is human agency. So what I'm talking about today at a sort of macro-theoretical level or meta-theoretical level is the problem of how we account for and characterize the things that people do when they do this in a structured and organized way. My work sometimes described as being located in the domain of implementation science, but what I'm describing here, I think, is a theoretical model that sits very firmly in the middle range of sociological theory. This is a highly applied theoretical model that we can use to understand different dimensions of agency in action across very specific kinds of contexts. We'll come to some of those later, but I just wanted to be clear at the outset that what I'm interested in here is human agency, how it's resourced, mobilized, and enacted, and how agency behaves when it encounters its own objects, as it were, when it encounters the things that we seek to implement or do or engage with, and how human agency interacts with material practices and material objects. For the purposes of this talk, I'm speaking very specifically about healthcare technologies and healthcare practices. I'm particularly interested in those. I always have been. But there's nothing that I'm talking about today that couldn't be extended elsewhere. And indeed, the kinds of theoretical models that I'm interested in and have promoted have focused on very, very diverse technologies and practices. So the very first use of normalization process theory, which is what I'm going to be talking about in a minute, was actually looking at launch procedures for Tomahawk cruise missiles on British nuclear attack submarines. Now, that's not something that I ever thought my work would contribute to, and it's not something that I feel very comfortable with. The point that I'm making, I guess, is that theories are generic and they apply to the whole range of practices, or they apply to none. And so my work's been used to, in those defense industry settings, but also to look at wine production in South Africa and Korean pop music in California. And you know when you're a sociologist and somebody starts using your theoretical concepts to analyze pop music, you know that you're there. So on now to think about theory. And Kurt Lewin is supposed to have said, the great American social psychologist who wrote so much about conflict resolution in the period after the Second World War, he's supposed to have said that there's nothing so practical as a good theory. And I think that's a tremendously helpful and useful characterization of theory, because theory is so often seen as an abstract and elevated business that sits above and hovers over empirical work. But for me, theory is a living, breathing thing. It's something we use as a toolkit to understand and characterize the social world, and to understand and characterize and explain our experiences in that world. And theory that doesn't do that isn't necessarily helpful theory. Much of what we currently see as theory is a kind of highly institutionalized and articulated meta-cleverness, rather than something that actually carries our understanding of the world forward very far. That's quite a controversial thing to say, perhaps, but I don't think theory is interesting for its own sake. I think theory is really interesting when we can apply it to observable and knowable empirical worlds. Well, in implementation science, there's no shortage of theory. Tabak and colleagues have identified more than 60 theories, models, frameworks relevant to implementation. And as I sort of have looked at these, I like Tabak's review very much, and I think this is one of those useful pieces of synthesizing and taxonomic research. It's exactly the kind of thing that we need to underpin our area of science with. But looking at the theories and models that they review, two things strike me. The first is that much of this work focuses on attributes of organizations and environments, and so it reflects the kind of interaction of diffusion of innovation models with theories of organizational behavior. And in this kind of context, it is the context that often matters. The receptive context theory, I think, is one way of characterizing it. The second dominant theme in this literature is actually a kind of individualistic psychologicalism that focuses very much on attitudes and intentions and is hugely influenced by social cognitive theory. And some of this work is really very powerful intellectually. So in that context, I'd point to Brian Weiner's theory of organizational readiness as a real theoretical advance in that area, an important one as well. But there's another thing that goes on here, which is there's much less interest in processes and much less interest in collective action as it informs implementation processes. And I think there are several reasons for that. The first is that these are difficult processes to characterize and investigate because they involve complex and emergent behaviors within populations, within different kinds of groups. And also because their outcomes are really difficult to understand and impossible to predict. Psychological studies often have reasonable capacity to make predictions, although those predictions very often don't come true. And many diffusion of innovation studies are really only done in retrospect. And towards the end of his life, Everett Rogers wrote very regretfully about the failure of his research program to generate prospective studies. Very, I think, poignant paper that is underpinned by a real problem for many qualitative investigations in this field, which is that by and large they are retrospective, their analyses are post hoc, and the integration of theory and empirical research reflects very often a retrospective interpretation of the data. And that's as true for some of my work as it is for everybody else's. This is another way of seeing the problem that I faced in the mid-2000s when I started doing this work. Again, we have robust science theories about individual differences, about the flow of innovations. But of course, the other really important body of theory in this area, actor network theory and science and technology studies, that's explored reciprocal relations between people and things. And I think that's a really, some of the scholarship there, and I point to work by my friends Maggie Mort and Tiago Moreira, amongst others, Andrew Webster and his group in York. Some really very, very important work there. But again, work that is difficult to think prospectively about, and which is almost completely refractory to formalization. Indeed, proponents of actor network theory, I think, wouldn't regard themselves as being interested in formalizing or testing their theories. People like Bruno Latour are worried that it's not a theory but a method. People like John Law, who's the other great proponent of this work, argue that the kinds of reification and objectification, as he sees it, of data that comes from prospective analyses that may include quantitative and qualitative methods, again, is something that he's reluctant to engage with. And it returns to the problem that I saw, which was that although there was much work about implementation, as though there was a lot of stuff about technology adoption and diffusion and the reciprocal relations between technology users and their practices and the material artifacts that they were working with, I sort of felt that there was an implementation-shaped hole in implementation science, that there was actually no useful body or coherent body of theory that researchers could draw on to understand the dynamics of these processes. So in 2005, I was very fortunate. I had an Economic and Social Research Council research fellowship in the UK, and I rather blithely wrote into the application for that I wanted to build some theory. What I thought I was going to do was to modify and reinterpret concepts in science and technology studies, but what I actually ended up doing was something that was really quite different. So I'm going to come to that now. This is, if you like, a picture of my research program. And it starts on the left-hand side of the screen with empirical studies, and there were a considerable number of those. I guess between 1987 and 2005, I guess I was probably involved in about 50, 55 empirical studies that bore relation to the problems that I've just described. And in two of those, we began to develop the notion of normalization, and we took this very specifically from the work of Michel Foucault. And we began to think about what would it mean if something became a set of practices or a set of classifications or a set of material artifacts became routinely embedded in everyday practice. What would that mean? And so our first stage, which I'll talk about in a minute, was a series of theoretical constructs about the relationship between people and interventions of different kinds. The second was about developing a theoretical model of the application of agency. And most recently, a kind of piece that's about integrating agency and objects and some aspects of their context. But this is played out in several ways, and the first way that it's played out is perhaps the most obvious one, which is in empirical studies of interventions and processes, but also the development of toolkits, and with my colleague Tracy Finch in Newcastle and other colleagues, the development of quantitative instruments to measure these theoretical constructs that we've created. The second way in which it's worked out with my colleague Francis Mayer and my colleague Victor Montori at the Mayo Clinic has been to develop ideas about minimally disruptive healthcare and the struggle that patients and caregivers face when they're required to normalize new practices and technologies into their life world. And that's in turn led to burden of treatment studies, where we begin to look at the impact of material artifacts, conceptual reclassifications, and healthcare practices in the life world, and explore the interaction between them and the burdens of illness. So there's a big kind of theoretical set of constructs here that have occupied me and colleagues now for nearly 10 years. The first phase of this was what I think we could usefully say was a formal grounded theory. I was very opposed to grounded theory as a doctoral student, and it took me a long time before, in fact it took me about 18 years before I felt that I could actually do grounded theory work. And the result of that was a set of constructs that helped us understand how users interact with interventions. And here I'm talking about complex healthcare interventions of different kinds. For example, telemedicine systems, where we're not just looking at the hardware, but we're looking at the range of social practices that that surround it, that make it possible, and that give both the users of technology and the technology itself some capabilities and affordances. And this was really, we empirically worked this up through through an extremely rigorous and painful process of secondary data analysis and proposition building, theory building in the classic sense. And here I was very influenced by the way in which Glaser and Strauss actually present their theory of status passage in their book, Status Passage, which I think is a really clever and interesting way of presenting a formal grounded theory. And I have to say that I lifted really stylistically the way that I presented the theory. All three iterations of normalization process theory have four key constructs, and this one just broke down how things work and what sorts of agency are involved, and how that agency is distributed and organized. It's a focus on collective action, but it was clear to me and to my colleague Tracy Finch in Newcastle, when we came to look at it and apply it in a series of additional studies, it was very clear that in fact that was insufficient. And we, with a very large group of researchers doing studies not just here in the UK, but colleagues in Canada, the United States and Australia, began to think about what extending that theory might look like, and began to develop a true middle range generic theory of implementation. We were much less concerned here with the objects that were to be implemented. We characterized them as ensembles of practices, and we characterized the settings in which those ensembles of practices were worked out only as social matrices. We made no claims about their organizational basis. And that's proven useful and important in the further development of the theory. Here we were developing what is effectively a theory of agentic contribution. We've already seen collective action here in the right-hand corner, but now we add to this the work of making some complex intervention coherent, mentally coherent, and culturally coherent in the groups that are likely to use it, and cognitive participation. In particular, the way that people legitimize some new classification or behavior or practice and enroll each other into operationalizing it. And then we have reflexive monitoring, and of course, if you're a researcher, then institutionally you commit reflexive monitoring all the time. It's what we researchers do. And the British sociologist Anthony Giddens has called reflexive monitoring the chronic condition of our time. And any of you who followed Deborah Lupton's recent work about the quantified self and other work that people are doing about the construction of subjects in late modernity, we're very busy monitoring ourselves and appraising the contributions or the outcomes of the things that we do constantly. Anybody who's had to construct an academic CV lately will know exactly what I mean. So the most recent version of this theory, I wasn't very well, and unfortunately I had to spend some time in hospital, and that, along with the fact that I had an administrative appointment that meant that I had to spend a lot of time in soul-sucking meetings of enormous duration, gave me an opportunity to write some further theoretical work, focusing now on not just on individual and collective agency, but how those relate to the dynamic features of the social matrices in which they're set. And what we've got here is, again, contribution, the agency that we've just been talking about, but also drawing on social structural theory, and especially the work of Ruschemeyer at Johns Hopkins, and at Boston, and people like Bandura and Asian and Fishbein, whose work on social cognitive psychology is really important. They actually built a much more robust and extensive model that kind of looks a bit like this, and where there are clearly feedback loops between the things that are going on. This is work that's contributed to some important, I think, and quite well cited, some of them, systematic reviews. I'm going to talk about the most recent one of these, which is work that I've been doing here in Southampton with my colleagues Catherine Hunt and Andy Sibley. Beginning with the question, well, what disposes something to normalization? I kind of really summoned out of the Air Clinical Practice Guidelines as a good example, because I had been on the periphery of a very interesting study done in the Department of Nursing Research at the Mayo Clinic that had looked at interventions for falls, guidelines to prevent falls in hospital, and activities to prevent falls in hospital. And that work hasn't been published yet, but I think is really interesting. And I took the theoretical propositions that had developed from the most recent iteration, the third iteration of normalization process theory. And these are very context independent, they're highly generic. But as a thought experiment, I took those and contextualized them against guidelines as an established clinical problem. And in that 2013 paper, reconstituted them, those generic propositions, as much more context-dependent ones. And I know that these slides are going to be available to you after the talk, so I'm not going to work through these two too much now, but what I then did was to actually kind of test them informally in a systematic review. And this has just become available online. It's a bit of a labour of love by the people who did it. It was we just did this quite significant piece of work without any external funding and without any time being dedicated to it. But like all systematic reviews of this kind, it's a review of qualitative studies of implementation of nursing practice guidelines. Its key inclusion criteria for papers, though, was that they provided sufficient detail for the reader to make sense of an implementation process. Now, you'd be astonished at how many reports, qualitative reports, of the adoption or implementation or operationalization of clinical practice guidelines actually tell you virtually nothing about the processes involved. I was astonished too. My colleagues Andy Sibley and Catherine Hunt, of course, weren't familiar with the new theory, and I wrote a coding frame for them to use, and that then informed directed content analysis, which was good fun. And then we began to work it up or I began to do the analysis, and we found very quickly an important problem in studies of the kind that we were looking at, and that was that authors told us almost nothing about the guidelines that they were implementing. We had no way of knowing what the guidelines themselves consisted of, were composed of. Authors were extremely cagey about this. But nevertheless, we could make some, on the basis of the earlier theoretical constructs that I've talked about, we can start to say make some positive claims based on the interaction of a theoretical interpretive model and the literature. And the first is, not surprisingly, that a guideline is disposed to normalization when nurses can minimize disruption to behavioral norms and agreed professional roles. I don't think anybody will be surprised by that. Much more important, I think, is the kind of information about the balance that nurses have to make between the workability of a guideline in their individual practice and the problem of integrating it into their collective workflow. I think this is really important, and we're doing some work now that has explored this in more detail in a different setting, and looking at individual variations in individual workability and how those pan out against collective workflow. A second and really important part of this is, of course, that guidelines sometimes don't differentiate themselves from existing practice in a careful and positive way. And that makes it difficult for their proponents to argue that these interventions are legitimate ways of reframing work. The claim that something is a means of translating evidence into practice is, of course, easily contested, and it is often contested by practitioners. Emergent communities of practice are also really very important here. And that again is about integrating the guideline into collective workflow, but actually also about finding ways to sustain it in that context. And of course, crucially, success is a visible success of a guideline is terribly important. So guidelines dispose to normalization when it's associated with improvements in the collective knowledge of its users. So that's not simply in terms of improvements in the applicability of things, but it's about how people begin to reframe and reconstruct problems in practice in relation to this new body of knowledge, and how that new body of knowledge is in turn integrated into workflow. So that's the very brief tour through the theory and its application in a systematic review of qualitative studies. We have other qualitative systematic reviews in process at the moment that, on different topics, that lead me to think that that this is a theory that works pretty well in predicting the outcomes or forecasting the outcomes of the implementation of some kinds of clinical interaction. Now, one of the things that I've tried to talk about and to demonstrate, and I'm running out of time, is that theoretical work is often abstract, but actually it can be used to interrogate visible work that's done to achieve important clinical goals. And that we can understand, using theories like this, the core elements of clinical knowledge and practice in process. And that in turn helps us understand large outcomes evaluation studies. So that's my my talk this evening for me, and at whatever time it is for you. That's what I look like, for those of you who care. And I'm very happy to have spoken to you this evening. Thanks for your attention. And now I'm interested in perhaps talking to you using this little sort of messaging device that I've got down here, which is going to tell me
Thank you very much, Carl.
about your question.
Thank you, Carl. I would like to invite all of you just to click on the hand icon, and I will give the microphone to you. And maybe in this way it would be easier to communicate and to ask questions or generate some kind of discussion. So if anybody of you would like to ask a question to Dr. May, you just have to click on the hand icon you have on control panel of GoToWebinar, and I will give the microphone to you. I see that Faye Mathem has the hand risen, so I will open the microphone to you, Faye. The microphone is yours. Faye, are you there? Faye, would you like to ask a question to Dr. May? It seems that not. So, of course, we can read questions. We have some questions. For instance, Sarah, she would like to ask you, what were your early reservations about grounded theory?
I've struggled to, looking at many reported grounded theories, I felt that they were neither theory nor grounded, and I'm not being facetious when I say that. I thought that many of the grounded theory studies that I read as a doctoral student and as a postdoctoral researcher were descriptive rather than explanatory. I think that I felt that they portrayed what I've subsequently seen called empirical generalizations. And all an empirical generalization is is a regularity in data that warrants explanation. But I thought very often the explanation was lacking, that there was a great deal of description and not much explanation. There were, of course, a number of people who were doing really extraordinarily explanatory work, but they were doing them on the basis of very large aggregated studies. So if you look at what Glaser and Strauss were doing in the 1960s, when they were kind of characterizing status passage theory, that was based on a number of extremely large and comprehensive studies. So beginning with the Boys in White study of medical socialization in Kansas in the 1950s, and then the work that they had done on psychiatric institutions and ideologies, and then the work that they had done on awareness, context, and dying, so that they had a very large and diverse body of data to draw on. And I felt that many grounded theory studies drew on very microscopic and myopic bodies of data and analysis. I think those were my reservations. I think grounded theory is fine, but I think it requires an aggregated body of data.
Yeah, because we had another question also from Gail. He also asked, why were you so against grounded theory to begin with? But I think that you pretty answered your question.
I'm not against it. I mean, I had reservations about what it was and what it meant. Like many researchers, I actually had to do it and be successful at doing it before I felt that I could say something positive about it.
Thank you very much. Yeah, I see that Roxana has a question, so I would like to open, Roxana, your microphone and just to give the microphone to you to ask a question. Roxana?
Yes, can you hear me?
Yeah.
Okay, I have also written a question. It just seems to me that this implementation whole is one that we struggle with in many of the forms of qualitative research, and it occurs to me that this, I guess, model that you are describing here is one that really almost any qualitative researcher could use to, sort of pass through these this model. We would need to really focus on the practitioner's response, the practitioner's acceptance of delineated findings or explicated findings, and so this is quite new to me as a qualitative researcher and something that I struggle with all of the time in terms of coming up with guidelines. But you're almost it seems to me that you're suggesting that this process is one that really allows us to put the practical aspect on the studies that we do. I mean, I find this to be quite helpful.
Well, I'm delighted that you feel that. I think I am interested in practice. I'm surrounded in my professional life by people who practice as healthcare providers as well as researchers, and people who are clinical academics. So I'm absolutely committed to theoretical constructs that help practitioners think through day-to-day problems, and that help them think through these problems using theoretical models prospectively, so that they can think about what might happen or what could happen if they do something, as well as analyze what has happened. And we have a toolkit that we can offer you, which is if I can just bring it up on screen. to help people with that task, we have a, oops, have I lost everything now? We have an online toolkit that people can use to work through those problems in advance and think about implementation processes as they do them. So I'm glad that you think that. The thing that I'd say about it, of course, is that there are some systemic problems in analysing practice. And what I'm trying to do with NPT is to develop a theoretical framework that is concerned with real and observable things that happen in the world, and that doesn't focus too much on people's beliefs and intentions and attitudes. Because I think that there's a really important thing here, which is about studying things that actually happen. And that's just me. I'm an old, I kind of quite like the notion that behavior is actually what counts. So that's where I'm coming from with this. I hope you found that answer helpful.
Thank you. We see another question from Betty. So, Betty, I will open your microphone. The microphone is yours.
Hello, this is Betty Wills from Alberta, Canada. Thank you. Can you hear me?
Yeah, I certainly can.
Dr. May, thank you so much. As you were speaking about the normalization process theory, I'm a grounded theorist. I did my doctorate dissertation under Janice Morse on grounded theory. And okay. I'm a very practical person, and I agree with you completely about the difficulty doing a good grounded theory. But I actually, as you speak about normalization, I must admit I like to implement research findings into everyday practice for nurses. But I think it's a very difficult knowledge transfer. As I argue, many of us who are doctoral prepared believe in research, but it always frustrates me with the fact that these research findings are never implemented to the scale that I would like them to. So I actually, as you speak, I was actually Google normalization process theory because I really don't know very much about it, and I actually found the website that you were just putting on right now. Yeah. For sure, I will be using that and implement, learning a little bit more about that theory and help me to implement this into general practice. Now, I'm a director of quality and risk for home care agency now in Alberta, and yeah. I am actually struggling. I'm not really struggling. I am actually being challenged now for myself to put these findings into practice for our healthcare providers who are not doctoral prepared or even at a diploma level. Mm-hmm. So I will hope that these normalization process theory, I will have to use it and to be very creative to engage these particular group of healthcare providers, because they are our backbones now of our healthcare providers in Canada anyway, that probably around the world, because we just don't have enough nurses. So I would really thank you for your great talk today.
Well, thank you very much, Betty. And actually, if you look on the website, if you're working with people who aren't doctorally prepared, then this is actually quite a good little presentation for them, because it actually, if you get to it, it simplifies everything, and it works around an example that everybody deals with in a hospital, which is falls prevention. So it kind of makes it clear what the different constructs and variables of the theory are. And then the other thing that I say about this is, if you work with a theory, how useful is it? And a theory is really useful if it can save you time and kill something that isn't going to work. And so these items, these different elements of the theory actually come together to set out 16 questions that can kill a complex intervention before you get down to doing it. And if you can do that, you can work through the questions here. And if you're getting kind of negative answers, then you know you've got some work to do before you begin to implement something. So thanks very much for those very helpful comments.
Thank you. And let's have the last question of Patricia. I see her hand risen. So Patricia, I will open your microphone and then we will finish the session.
Okay.
Patricia?
Okay, thank you. Can you hear me?
Yes, ma'am.
Okay, that's terrific. Otherwise, I would type the question out. Thank you for your talk. It was very, very interesting. And I had already taken a peek at the toolkit. And it's very generous of you to post that and offer it up. It's an excellent presentation as well. What I was wondering if you could comment on, because I agree with you, I do social network analysis research. And when you said you like to study real things that happen in the real world and look at things that actually happen, that's what I like to do too, and I like to apply network analysis to look at relational aspects. So I wondered if you could comment on how that social network theory either impacted or didn't impact your development of the theory. And I know you had it in one of the charts. It had a little box on the right-hand side. At least I interpreted that box to be, okay, that's where social network impacts might be picked up.
Right. Okay. Well, that's a big question for 3 minutes.
I know.
Let me give it a go. The first thing to say is that social networks and the strategic action fields that they encompass are the basic building blocks of social life. And so when we're looking at the embedding of practices, we are sometimes looking at the embedding of practices, their normalization across complex and distributed networks. So I've been very, very aware of networks, not simply as, if you like, the means of transmission by which innovations or ideas move around, but also, if you like, as the place where norms and rules and roles are embedded that promote or inhibit that stuff. And in fact, I'm just about to begin a project here in the UK, which is going to look at NPT in part from the perspective of social network analysis. So if you want to email me, I'll keep you in touch with that.
Thank you very much, Carl. Thank you for your great presentation. We have more questions, but maybe it would be better to follow the discussion through email later on, because
yeah, I'm very happy for people to email me or phone me or contact me on Twitter. I'm kind of rather more networked than the fact that I can't use any kind of technology would suggest.
Okay.
So, you know, by all means, love to have the debate, love to share the excitement of this kind of work. Thank you, everybody.
Thank you for you, Carl. Now I would like to give the microphone to Amanda Schroer, the Director of International Institute for Qualitative Methodology, to make some announcements, and then we will finalize the session. So, Amanda, the microphone is yours. Amanda?
Thank you, Narendra. Yes, I just have one quick announcement, and that is that we are accepting applications for the ATLAS.ti IIQM Dissertation Awards, and those applications will be accepted until November 28th. I encourage everyone to think about applying, or if you know somebody that would be eligible, to encourage them to apply, because these are annual awards and they are for the best master's level dissertation and one other award for the best PhD level dissertation from any academic discipline. And the successful applicant receives $3,000 as well as an ATLAS.ti software license, complimentary training for that software, and complimentary registration to either the Advances in Qualitative Methods Conference or the Qualitative Health Research Conference in 2014. So all information about those can be found on our website, iiqm.ualberta.ca, as well can the notes from Carl's talk and a YouTube video which will be posted later on, so you can access the webinar that way as well. So, and I'd just like to thank Carl for presenting today.
Thank you very much. It's been a pleasure.
And can you hear me? It seems that...
Yeah, I can hear you.
I just wanted to add to Amanda's announcement saying that if anybody wants to learn ATLAS.ti, we offer every week free webinars, so you can go on the website of ATLAS.ti and learn more about that. So we also will send you an evaluation form, and we will send you a link where you will find the video recorded of the session and the PowerPoint presentation. So I want to say thank you all for participating in this webinar. It was very important to count on all of you. Your participation makes this series successful. So would you say goodbye, Carl, and we will close the session for today.
Okay, bye-bye everyone.
Bye. Thank you very much, Carl. Thank you, and bye-bye.